Thank you very much for the kind words, and welcome, everyone. We're going to be addressing observation today. Email address. Slide number 2. You can read about me at your leisure. It is true that my favorite reading material is the Federal Register, and boy, we seem to have a lot of really long Federal Registers, and as a matter of fact, we should have 2 Federal Registers out any day now, relative to the outpatient prospective payment system and the Medicare physician fee schedule payment system as well. Slide number 3 is a little disclaimer. I'll simply summarize it by saying to you, I will give you the very best I have today. Whenever we are in a compliance area in health care, things can become a little bit ambiguous. I wish that the world were purely black and white, particularly as the federal auditors would make it out to be. It's not quite that simple, everyone. So whenever you're looking at a particular situation, a particular problem, sufficiency of documentation, whatever it is, be sure that you get multiple resources giving you the same guidance or the same answers to your questions. And for those of you that have been in healthcare for more than 10 years, realize very quickly getting, for instance, 3 independent resources to say the same thing about the same set of facts, the same question, is almost mission impossible these days. All right, so I'll just leave it at that. Slide number 4. Well, what are we doing today? Well, today we're going to be looking at the complex issues involving observation admissions. Now, again, your phraseology may be different. Observation, according to Medicare at least, is not a status. It is not a status, even though we kind of treat it as a status. But we have this whole observation admission. Now, you have to be careful because I have, over the years, I've sat down with doctors and we've discussed observation. For some doctors, particularly more senior or mature doctors, the concept of observation is automatically inpatient. I mean, they really think of observation as being an inpatient service. Okay, so just keep that in mind, please, as you work with this. Now, one of our big challenges is to separate appropriately and to distinguish between inpatient admissions and what I will call observation admissions. In other words, inpatient versus outpatient. This is where we get into the over 2 midnight rule, and we can't avoid it. There's no way to avoid it, so we'll simply discuss it to some extent, even though we could probably spend the rest of the day talking about the over 2 midnight rule. Now, I'm going to presume that you've had some experience, some background in this area, that you have certain policies and procedures in place. For instance, we will discuss, but only passingly, when observation starts and when it stops. Also, we need to have policies and procedures in place as to how we count the number of hours for observation for billing purposes, which we now know is different from counting the number of hours for observation services relative to the Notice Act and the implementation of the MOON form, the Medicare Outpatient Observation Notice form. We count those differently, okay? So you need to make certain that you have policies and procedures in place so that you are doing this correctly. Now, I'll point out a little bit later in a quote from the Federal Register that CMS refuses to adopt national standards for inpatient admission criteria. Now, this has some distinct meanings, and this is where we get into the over 2 midnight rule, because is the over 2 midnight rule, is that a payment rule, or is it a clinical rule? That is, if the patient needs hospital services over 2 midnights, they are automatically an inpatient, at least for Medicare beneficiaries, or is it both a payment and a clinical rule? And that's a